chapter 16, and we'll be discussing about immunity to microbes. We'll have maybe 2 sessions for this reading, and we'll look at what will happen from after 1 hour, see if there's anything remaining significantly that we can do. Otherwise, let us continue. Overview of immune response to microbes. Here we'll speak about immunity to extracellular bacteria, innate immunity to extracellular bacteria, adaptive immunity to extracellular bacteria, injury effects of immune response to extracellular bacteria, immune evasion by extracellular bacteria. We'll discuss further on immunity to intracellular bacteria, the innate and adaptive immunity, immunity to fungus or to fungi, immunity to viruses, immunity to parasite, and strategy for vaccine development, attenuated and inactivated bacteria and viral vaccines, purified antigen, synthetic live virus DNA vaccine, messenger RNA vaccine, adjuvant, and other things that will be discussed. So it's a very nice topic. Hopefully we will enjoy. Let us go. In the preceding chapter, we have referred to a protection against infection as the major physiological function of the immune system and discussed immune response in the context of response to microbes. In this chapter, we will integrate this information and discuss the main features of immunity to different types of pathogenic microorganisms, as well as mechanism microbes use to resist immune defenses. Development of an infectious disease is an individual involves development of an infectious disease in an individual involves complex interaction between the microbes and hosts. The key events during infection include entry of the microbes, invasion and colonization of the host tissue, evasion of the host immunity, and tissue injury and functional impairments. Microbes produce disease by killing the host cell, the infectee, or releasing toxins that can produce tissue damage and functional derangement in neighboring or distant cells and tissue that are not infected. In addition, microbes often causes disease by stimulating innate and adaptive immune responses that kills the microbes, but also may injure and impair the function of normal tissue. Many features of microorganism determine their virulence, and many diverse mechanisms contribute to the pathogenesis of infectious disease. The topic of microbial pathogenesis is beyond the scope of this book. Our discussion will focus on host immune response to pathogenic microorganism. Overview of immune response to microbes. Microbes can cause disease of varying severity and chronicity. In many instances, an infection is asymptomatic and resolved without intervention. A typical host immune response is rapidly triggered by the infection once as the infection is cleared and leave the memory cell that can provide a long-term protection. Recurrent illness occur when host response cannot eradicate the microbes and may even contribute to the disease. Although antimicrobial host defense reactions are numerous and varied, there are several important general features of immunity to microbes. Defense against microbes is mediated by the effector mechanism of innate and adaptive immunity. The innate immune system provides L defense, and adaptive immune system provide a more sustained and stronger response, as well as protection against repeat infections by the same microbes. Many pathogenic microbes have evolved to resist innate immunity, and the protection against such infection is critically dependent on adaptive immune response. Adaptive immune responses are effective against even virulent microbes, because they generate large number of effector cells and the antibody molecules that function to eliminate the microbes and memory cells that, that protect the individual from repeated infection. However, it typically takes several days for adaptive immune response to develop the time needed for naive lymphocyte proliferation and differentiation into effector cell. And the innate immune provide a critical defense during this window. So this we have the figure 16,1, and this is the progression and outcome of infection. Mostly infections have an incubation period followed by disease that may be short-lived if the host response is effective, or progressive or chronic if the response does not adequately control the infection. So when you look at this one, you see rapidly eradicated by host response, then you don't go to the symptoms. So the first thing is innate immune response in almost all the time, whereby the disease still in incubation is dealing with innate immune response. Adaptive immune response and memory occur when the disease is almost already. So if no control, things happen. If the control is good in innate, that's things down. If control was good in innate but not that much good goes, even there is a moment whereby the adaptive immune comes in. So it's something like that. The immune system responds in a specialized and distinct way to different types of microbes to combat these infectious agents most effectively. Different microbes require different mechanisms for elimination, and adaptive immune systems have evolved to respond in the optimal way to diversity of microbes. The generation of different microbe or different subset of effector CD4 T cells, seen in chapter 10, and production of different isotypes of antibodies, seen in chapter 12, are excellent examples of specialization of adaptive immunity. The survival and the pathogenicity of microbes in a host are critically influenced by the ability of microbes to evade or resist the effector mechanism of immunity. As we will see later in this chapter, microorganisms have developed a variety of mechanisms for surviving in the face of powerful immunological defenses. Infectious microbes and the immune system have co-evolved and are engaged in constant struggle for survival. The balance between host immune responses and microbial strategy for resisting immunity often determine the outcome of infection. Some microbes establish latent or persistent infection in which the immune response controls but does not eliminate the microbes. Several viruses, especially DNA viruses of the herpes viruses and pox viruses families, and some intracellular bacteria are capable of establishing latent infection. In latent viral infection, the viral DNA persists in the genome of infected cell, but no infectious virus is produced. In the persistent bacterial infection, such as tuberculosis, the bacteria may survive within a phagocytic vesicle of infected macrophage. In all of these situations, some latent microbes will on occasion become activated and start replicating, especially if the immune system is weakened by any reason. In many infections, tissue injury and disease may be caused by host response to microbes rather than the microbe itself. Immunity is necessary for the host survival, but also has the potential for causing injury to the host. Inherited and acquired defect in innate and adaptive immunity are important causes of susceptibility to infection. Commonly acquired causes of immunodeficiency include human immunodeficiency virus infections and therapeutic immunosuppression by drugs to treat inflammatory or autoimmune disease or to prevent transplant rejection. Although less common, there are a larger number of inherited immunodeficiency syndrome caused by mutation in single genes whose major clinical consequences is increased infections. In addition, SABO or poorly defined defect in host defenses may underlie common infection. We will describe the immunodeficiency in detail in chapter 21. Aging individuals are also show increased susceptibility to infection, presumably because of reduced adaptive immune response. Paradoxically, with age, there are also increased inflammation without overt triggers. Infection in the population elicit immune response that establish herd immunity, which protect against the spread of infection. Conversely, newly emerging infections are able to spread in part because of the absence of herd immunity, resulting in epidemic and pandemic. Most of these new infections are caused by viruses that develop novel strain because of reassessment between the genomes of existing human strain and animal strain. This is the this is the this is discussed in more detail later when we consider how influenza viruses escape from the immune defense. The most devastating pandemic in recent history was caused by influenza virus in 1918 and to 1920s, estimated to have killed 20 to 50 million people in Western Europe and other regions of the world. The more recent widespread infection has been caused by coronavirus that caused severe acute respiratory distress syndrome SARS in 2012 and 2, a new influenza strain in 2009, coronavirus that caused the Middle Eastern respiratory syndromes MERS, which is emerged in 2012, Zika virus in 2015, which caused the neurological defect in newborn, and coronavirus SARS-CoV-2 from 2019 onward, which causes the disease called COVID-19. The rapid spread of COVID-19 pandemic, which has caused over 2 million deaths by early 2021. The major disruption in society worldwide demonstrate this extreme danger of emerging disease in populations that lack pre-existing immunity. Analysis of immune response is a valuable clinical assay for infections. The most useful tool test is measuring the serum antibody specific for particular microbes. This is helpful for determining infections in which the microbes cannot be captured. Is not detectable in the blood by molecular assay, or it is present in tissue that are not readily accessible. The presence of IgM, immunoglobulin M, antibodies indicates of recent infection, whereas the presence of only IgG suggests past infection, reflecting the consequence of antibody isotype production. IgM followed by IgG in response to NA immunization, chapter 12. Other tests include assays for T cell response, such as tests for skin reaction to microbial antigen and cytokine, e.g. interferon gamma released after activation of peripheral blood cell with antigen used to detect infection with Mycobacterium tuberculosis. So, example of pathogenic microbes. So, microbes, we have Staphylococcus aureus, for example. Example of human disease mechanism of pathogenicity. So this Staphylococcus aureus, the skin, affect the skin and soft tissue infection, lung abscess, systemic toxic shock syndrome, food poisoning, etc. The skin infection, acute inflammation induced by toxin, cell death caused by pore forming toxin, system toxin, super antigen induced the cytokine production that by T cell causing skin necrosis, shock, diarrhea, etc. We have Streptococcus pyogenes, group A. This causes pharyngitis, skin infection, impedigos, erythrosis, cellulitis, systemic scarlet fever. It damages the cell membrane generally. It causes acute inflammation, induced various toxin, streptolysin ores, damage the cell membrane. We have Streptococcus pneumococcus, pneumonia meningitis, the disease that can be caused, and Actually, it causes or mechanism of pathogenesis acute inflammation induced by cell wall constituent pneumolysins in similar streptolysins or Escherichia coli is mostly affecting it causes the urinary tract infection, gastroenteritis together with septic shock. It will produce the toxin-induced intestinal epithelial chloride and water secretion. Endotoxin LPS stimulates cytokine secretion by macrophage. We have Vibrio cholera, a diarrhea cholera. This is cholera toxin, ADP ribonuclease G proteins subunit leading to increased cyclic MP intestinal epithelial cells resulting in chloride secretion and water loss. We have Clostridium tetanus. This is tetanus toxin binding to the motor end plate of neurotransmitters, neuromuscular junction, and causes irreversible muscle contraction. We have Corynebacterium diphtheria. These are the ones cause diphtheria. For example, diphtheria, the mechanism diphtheria toxin, ADP ribocyclase elongation factor 2 and inhibit protein synthesis. We have facultative intracellular bacteria, for example, Mycobacterium tuberculosis. This causes tuberculosis, and the main function or mechanism is macrophage activation resulting in granulomatous inflammation and tissue destruction. The Salmonella typhoid is enterocolitis and continue. So other microbes are Neisseria meningitis, which cause meningitis, and the mechanism of action is acute inflammation or systemic disease caused by potent toxin. We have Listeria monocytogenes, which cause listeriosis. This causes listeriolysin damaged cell membrane. We have Legionella pneumophilia, causes Legionella's disease, causes the mechanism of action is cytotoxin lyse cell and causes lung injury and inflammation. We have obligate intracellular bacteria. These are Microbacterium repri, which causes repress. It works by destructive or granulomatous lesion associated with a varying degree of cell-mediated immune response. We have chlamydia, which causes urogenital and eye infection. It's due to acute inflammation. Rickettsia, which causes typhus, other diseases. It is mostly endothelial infection and dysfunction. We have extracellular fungus, the Candida albicans. This causes the candidiasis, and it's mostly of acute inflammation bind complement proteins. Aspergillus fumigatus causes aspergillosis. It's also inversion and thrombosis of blood vessel causing disease. We have intracellular fungus, which is, for example, Histoplasma capsulam, which causes histoplasmosis. This causes lung inflammation. Infection causes granulomatous inflammation. We have Pneumocystis jirovecii, which causes pneumonia. Impaired macrophage clearance in setting of impaired T-cell immunity, leading to alveolar inflammation. We have Cryptococcus neoformans. This causes cryptococcus. This is due to multiple virulence factor. We have viruses, for example, polio, which causes poliomyelitis. Inhibit host cell protein synthesis tropism for motor neurons in the anterior horns of spinal cords. Influenza causes pneumonia. Inhibit host cell protein synthesis for tropism for ciliated epithelia. Rabies causes encephalitis. Inhibit cell protein synthesis tropism for peripheral nerves. Herpes simplex, various types infection, skin and systems, inhibit host cell protein synthesis, function impairment of immune cells. Hepatitis A, B, and C, these are viral hepatitis, host cytotoxic T cell response to infected hepatocytes. Epstein-Barr viruses, infectious mononucleosis, B cell proliferation lymphomas, acute infection cell lysis tropism for B cell lymphocyte, latent infections stimulate B cell proliferation. HIV, which causes AIDS, is multiple killing of CD4 T cells, functional impairment of immune cell. We'll discuss more on that on chapter 20. So these tables compiled with the assistance of people at the Department of Pathology, Harvard Medical School, Brigham Women Hospital. Just it is for compilation purpose, and I think you get some picture on how it looks like. So let us continue. In this chapter, we will consider the main features of immunity to 5 categories of pathogenic microorganisms: the extracellular bacteria, intracellular bacteria, fungus or fungi, viruses, and protozoa and multicellular parasite. See in table 16.1, see in table 16.4 later in the chapter. This separation provides a useful context of discussing immunity because the dominant immune response to these types of infections are different. We use the term extracellular and intracellular bacteria to refer where the organisms survive and replicate. Even extracellular bacteria become intracellular when they are ingested into the phagocytes, but they do not survive inside phagocytes. Our discussion of immune response to these microbes illustrates the physiological significance of the effector function of lymphocytes discussed earlier in the chapters. Immunity to extracellular bacteria. Extracellular bacteria are capable of replicating outside the cells, for example, in the bloods, in connective tissue, and in tissue space such as lumens of the airway or gastrointestinal tract. Many different species of extracellular bacteria are pathogenic, and disease is caused by 2 principal mechanisms. First, these bacteria induce inflammation, which results in tissue injury and site infection. Second, bacteria produce toxin, which have diverse pathological effects. The toxin include endotoxin, which is lipopolysaccharides complex in the wall of gram-negative bacteria, and endotoxin, which are secreted by many types of bacteria. Endotoxin activate macrophage and other cells and stimulate the production of cytokines that mediate host defense and also cause disease. Many exotoxins are cytotoxic and kill host cells, and other causes disease or virus mechanism. For instance, diphtheria toxin shut down protein synthesis in infected cells. Cholera toxin interferes with ions and water transport. Tetanus toxin inhibits neurotransmitter transmissions. And anthrax toxin disrupts the several critical biochemical signaling pathway in infected cells. Innate immunity to extracellular bacteria. The principal mechanism of innate immunity to extracellular bacteria are phagocytosis, complement activation, and inflammatory response. The activation of phagocytes and inflammation. Extracellular bacteria are efficiently killed by phagocytes, this is neutrophil and macrophage, because these microbes have not adapted to surviving inside these cells. Therefore, recruitment and activation of phagocytes to the site of infection, which is part of inflammatory response, is the major defense mechanism against these microbes. Phagocytes are recruited and activated in response to bacteria products which act directly on phagocytes and also influence secretions of cytokines that act on the cells. Tissue resident dendritic cells and macrophages that are activated by microbes secrete cytokines that promote leukocyte infiltration into site of infection. Recruited is neutrophil and blood monocyte derived macrophage as well as tissue resident macrophage use surface receptor including Mannose receptor and scavenger receptor to recognize extracellular bacteria and use FC receptor and complement receptor to recognize bacteria opsonized with the antibodies and complement protein respectively. Microbial products activate toll-like receptor and other pattern recognition receptor in phagocytes and other cells. Some of these receptors function mainly to promote phagocytosis of microbes, e.g. Mann's receptor, scavenger receptor, and others stimulate the microbicidal activity of phagocytes, mainly toll-like receptor, and yet others promote the phagocytosis and activation of phagocytes, Fc and complement receptor. The activated phagocyte ingests microbes and destroy them mainly in phagolysosomes. Complement activation. Bacteria provide a surface for complement activation by alternative pathway. We have seen in chapter 4 and 13. Bacteria expresses mannose on their surface that bind to mannose binding lectin, N-acetyl compound that bind to ficolins, both which activate complement by lectin pathway. One result of complement activation is opsonization and enhanced phagocytosis of bacteria. In addition, the membrane attack complex MAC generated by complement activation lyses bacteria, especially Neisseria species, which are particularly susceptible to lysis because of their thin cell walls, and complement byproduct stimulate inflammatory response by recruiting and activating leukocytes. Innate lymphoid cells, gamma delta T cells, and natural killer T cell have all been described in the infection, mostly in experimental model, but their roles in host defense, especially in human, is not established. Adaptive immunity to extracellular bacteria. Humoral immunity is the major protective immunity response against the extracellular bacteria, and it functions to block infection, to eliminate the microbes, and to neutralize the toxin. Antibody response against extracellular bacteria are directed against cell wall antigen and toxin, which may be polysaccharides or proteins. The polysaccharides are T-independent antigen that elicit antibody response but do not activate T cell. Therefore, humoral immunity is the principal mechanism of defense against polysaccharide-rich encapsulated bacteria. For these microbes, including Streptococcus pneumoniae, Neisseria species, and others, the spleen plays a major role in both production of the antibodies and phagocytic clearance of the opsonized bacteria. People whose spleens are either surgically removed because of trauma or other reasons are damaged in hematopoietic disorder are at risk of increasing risk of severe infection by these encapsulated bacteria. Protein antigen, which are present in or secreted by most bacteria, elicit most potent isotope switching, high affinity antibodies, as well as cell-mediated immunity. The effector mechanism all used by antibody to combat infections include neutralization, opsonization, and phagocytosis, and the activation of complement by classical pathway. Neutralization is mediated by high affinity IgG, IgM, and IgA isotopes, and later mainly in the lumen of mucosa organs. Opsonization is mediated by IgG1 and IgG3 subclasses of IgG, and complement activation is initiated by IgM, IgG1, and IgG3. So we have the diagram here and the figure. So this is explaining about the adaptive immune response to extracellular microbes. Adaptive immune response to extracellular microbes, such as bacteria and their toxin, consist of antibody production and the activation of CD4 helper T cell, which work by secretory cytokine B, and CD40 ligands not shown. Antibody neutralize and eliminate microbes and toxin by several mechanisms. Helper T cell produce cytokine that stimulate inflammation, macrophage activation, and B cell response. So generally we have bacteria. Then bacteria is taken up with B cells. Then if we take by B cell, the B cell will produce antibodies. Then antibody will either neutralize it or will opsonize it to be taken by other cells, and or this but other cell may phagocyte with complementary system and other things. Sometimes also there'll be recruitment of neutrophil and other things around for inflammation. So complement system can start. On B, bacteria can come in, and there's a dendritic cell which takes the bacteria and present it to CD4 helper T cell. As normal, this one will either produce it depends. It either produce interleukin 17, tumor necrosis factor, and other cytokine, or produce interleukin alpha or various cytokines. This one they can cause the macrophage to be part of to macrophage, and macrophage activation can lead to the phagocytosis and things like that. So we go. The protein antigen of extracellular bacteria also activate CD4 plus helper T cell, which produce cytokine and express cell surface molecules that induce local inflammation and enhance the phagocytic and microcidal activities of macrophage and neutrophil and stimulate antibody production. The T helper 17 response induced by these microbes recruit neutrophil and monocyte and thus promote local inflammation at site of bacterial infection. Patients with genetic defect in T helper 17 development and those who make neutralizing autoantibodies specific for T helper 17 have increased susceptibility to extracellular bacteria and fungal infection. And develop multiple skin abscesses. Injuries effect of immune response to extracellular bacteria. The principal injuries consequences of host response to extracellular bacteria are inflammation and sepsis. The same reaction of neutrophil and macrophage that function to eradicate infection also cause tissue damage by local production of reactive oxygen species and lysosome enzymes. These inflammatory reactions are usually self-limited and controlled. Cytokines secreted by leukocytes in response to bacteria products also stimulate production of acute phase protein and causes systemic manifestation of infection. Sepsis is the pathological consequence of severe local or disseminated infection by some gram-negative or gram-positive bacteria as well as some fungus. Sepsis typically manifests clinically with abnormality in tissue, blood perfusion, coagulations, metabolism, and organ functions. Septic shock is the most severe and frequently fatal forms of sepsis, characterized by circulatory collapse shock and disseminated intravesicular coagulation. The L's phase of bacterial sepsis is caused by cytokine produced by macrophage that activate the bacterial cell wall component, including LPS and peptoglycan. Tumor necrosis factor, interleukin 6 and interleukin 1 are the principal cytokine mediator of sepsis, but tumor necrosis factor, interferon gamma and interferon 12 and interleukin 12 may also contribute. This L burst of large amount of cytokines is sometimes called cytokine storm. There is some evidence that LPS induced sepsis, activation, and non-conical inflammation pathway causing cell death and release of inflammatory mediator, the process called pyroptosis. And this is essential for development of the disease. So see the diagram. This is the figure 16.3 polyclonal activation of T cell by bacteria super antigen. So A is the conventional microbial T cell antigen composed of peptide bond to peptide binding groups of major histocompatibility complex molecule and are recognized by very small fraction of T cell in and any one of individual, and only these T cells are activated to become effector T cell that protect against microbes. That's normal. Then B, in contrast to super antigen, bind to class 2 MHC molecule outside the peptide binding grooves in an non-specific manner. They simultaneously bind to variable region of many different T cells So this one you have super antigen, whereby it binds to several other, like it is binding to several other T cells. So different super antigen bind to T cell of different V beta families. Because many T cell expresses T cell receptor beta chain from the particular V beta family, super antigen can activate large number of T cell. In the example shown, the super antigen Staphylococcus enterotoxins SEB bind to human leukocyte antigen HLA-DR, the V region of T cell receptor belong to V beta 3 family. Other super antigen may bind different class of MHC class 2 molecules and T cell receptor of different V beta families, antigen presenting cells. Certain bacteria toxins stimulate all T cell that expresses member of particular T cell receptors, the T cell V beta gene family. Such toxins are called super antigen because, like the typical antigen, T cell recognize they bind to T cell receptor and to class 2 major histocompatibility complex molecule through not to peptide binding cleft, but they activate many more clones of T cell than do conventional peptide antigen. The importance lies in the ability to activate many T cells with subsequent production of large amount of cytokine that also cause sepsis-like system inflammation response syndrome. A late complication of humoral immune response to bacteria infection may be generation of disease-producing antibodies. The best defined example are two rare sequelae of streptococcal infection of the throat skin that manifested weeks or even months after infection are controlled. Rheumatic fever is sequel to pharyngeal infection with group A or beta hemolytic streptococcal. Infections lead to the production of antibodies and activation of T cells specifically for bacterial cell wall protein. Some of these antibodies and T cells cross-react with the myocardial proteins and cause inflammation affecting the heart muscle, myocarditis, and the valve, endocarditis. Post-streptococcal glomerulonephritis is a sequel to infection of the skin or throat with the nephrogenic strain of group A beta hemolytic streptococcus. Antibodies produced against these bacteria form complex with the bacterial antigen, which may be deposited in kidney, glomerule, and cause nephritis. Immunization by extracellular bacteria. The virulence of extracellular bacteria have been linked to a number of mechanisms that enable the microbes to resist innate immunity. You will see in table 16.2. Bacteria with polysaccharide-rich capsule resist phagocytosis and are therefore more virulent than homologous strains lacking a capsule. The capsule of many pathogenic gram-positive and gram-negative bacteria contain salicylic acid residue that inhibit complementary activation by alternative pathway. A mechanism used by bacteria to evade humoral immunity is variation on surface antigen. Some surface antigen of bacteria such as gonococcal and Escherichia coli are contained in their pill, which are the structural responsible for bacterial adhesion to host cell. The major antigen of pill is protein called pillin. The pillin genes of gonococcal undergo extensive gene conversion, because of which the progenitors of one organism can produce up to 10 power 6 antigenical distance pillin molecule. This ability to alter antigen helps the bacteria to evade attack by pillin-specific antibody. Although its principal significance for bacteria may be to select for the pill that are more adherent to host cell, so that bacteria are more virulent. This ability of to alter antigen helps the bacteria to evade attack by pill-specific antibodies. Although its principal significance for the bacteria may be to select a pill that are more adherent to the host cell so that the bacteria are more virulent. Changes in the production of glycosides lead to the chemical alteration of surface oligosaccharides, which enable the bacteria to invade humoral immune response against these antigen. Bacteria also release surface antigen in membrane blebs, which may divert antibody away from microbes themselves. Mechanism of immune evasion by bacteria. So mechanism of immune evasion, we have extracellular bacteria, antigenic variation, e.g. Neisseria gonorrhea, Escherichia coli, and Salmonella typhorum. Inhibition of complement activation, many bacteria. Resistance to phagocytosis, pneumococcus, Neisseria meningitis. Scavenging of reactive oxygen species, catalyze positive bacteria, including Staphylococcus and many others. Intracellular bacteria, inhibition of phagolysosomes formation, example Mycobacterium tuberculosis, Legionella pneumophila. Inactivation of reactive oxygen and nitrogen species, Microbacteria repri, phenolic glycolipid. Disruption of phagosomes membrane escape in the cytoplasm. For example, Listeria monocytogenes that disrupt the phagosome membrane escape cytoplasm. Immunity to intracellular bacteria. Intracellular bacteria are those that are ingested by macrophage but are able to survive and even replicate within cells. Because these microbes find a niche where they are inaccessible to circulating antibodies, their elimination requires a mechanism of cell-mediated immunity. As we will discuss later in this section, in many intracellular bacteria infection, the host response also causes tissue injury. Most bacteria do not infect non-phagocytic cells as they do virus. Therefore, a primary mechanism of host defense against such bacteria is to activate phagocytes to destroy the ingested microbes. Some bacteria do not infect non-phagocytic cells. Some bacteria do infect non-phagocytic cells, including Rickettsia species that infect endothelial cells and Chlamydia species that infect epithelial cell. A mechanism of defense against these bacteria is killing of infected cells for cytotoxic T lymphocytes, CTLs. Innate immunity to intracellular bacteria. The innate immune response to intracellular bacteria is mediated mainly by phagocytes and natural killer cells. Phagocytes, initially neutrophil and later macrophage, ingest and attempt to destroy these microbes, but pathogenic intracellular bacteria are resistant to degradation within phagocytes. Products of these bacteria are recognized by toll-like receptor and cytoplasmic proteins of node-like receptor, family resulting in activation of phagocytes. Bacteria DNA and cyclic denucleotide produced by bacteria in the cytosol stimulate type 1 interferon response through a STING pathway. So we have this, the mechanism of immune evasion in bacteria shown are the multiple mechanisms used by bacteria species Neisseria to evade humoral immunity, i.g. immunoglobulins. So you see Neisseria, microbial antigen specific i.g. the cellulation, they can produce oligosaccharides. There are different mechanisms. So you will have to look and study it. Control of infection. This is innate adaptive immune to intracellular bacteria. The innate immune response to intracellular bacteria consists of phagocytes and natural killer cells. Interaction among which are mediated by cytokines, interleukin 12 and interferon gamma. A typical adaptive immune response to these microbes is cell-mediated immunity, in which T cells activate phagocytes to eliminate the microbes. Innate immunity may control bacterial growth, but elimination of bacteria require adaptive immunity. These principles are based largely on the analysis of Listeria monocytogenes infection in mice. The number of variable bacteria shown on the y-axis are relatively value of bacteria colonies that can be grown from the tissue of infected mice. Intracellular bacteria activate natural killer cells by inducing expression of natural killer cell activating ligands on infected cell and by stimulating dendritic cell and macrophage producing of interleukin 12 and interleukin 15, both of which are natural killer cells activating cytokines. The natural killer cell produce interferon gamma, which in turn activate macrophage and promotes killing of phagocytosis bacteria. Thus, natural killer cells provide an early defense against these microbes before the development of adaptive immunity. In fact, mice with severe combined immunodeficiency which lack T and B cells are able to transiently control infection with the intracellular bacterium Listeria monocytogenes by natural killer cell derived from interferon gamma production. However, innate immunity usually fails to eradicate this infection, and eradication requires adaptive cell-mediated immunity. The ability of type 1 innate lymphocyte cells to defend against intracellular bacteria has been demonstrated in mouse model. The innate cell receptor secretes interleukin gamma and tumor necrosis factor which activate macrophage and help the clear intracellular pathogen. Adaptive immunity to intracellular bacteria. The major protective immunity response against intracellular bacteria is T cell mediated in recruitment and activation of phagocytes, cell-mediated immunity. Individuals with deficient cell-mediated immunity, such as with the AIDS, acquired immunodeficiency syndrome, are extremely susceptible to infection with intracellular bacteria as well as the intracellular fungi and virus. Many of the important features of cell-mediated immune were established in 1950 based on the studies of immune response to intracellular bacteria. Bacterium Elo monocytogenes in mice. This form of immunity could be adaptively transferred to naive animal with lymphocyte, but not with serum from infected or immunized animal. As we discussed in Chapter 10 and Chapter 11, T cells provide defense against infections by two types of reaction. CD4 plus T helper 1 cells activates phagocytes through the activation of CD40 ligands and interferon gamma, resulting in the killing of microbes that are ingested by phagocytes into the phagolysosomes, and CD8 plus cytotoxic T cell kills infected cell, eliminating microbes that escape the killing mechanism of phagocytes. CD4 T cells differentiate into T helper 1 effector under influence of interleukin 12, which is produced by macrophage and dendritic cell. The T cell express CD4 ligands and secrete interferon gamma, and these two stimuli activate macrophage to produce several microcidal substances, including nitric oxide, lysosome enzymes, and reactive oxygen species. These substances are produced mainly within phagolysosomes and thus target microbes ingested in the vesicle. The importance of interleukin 12 and interferon gamma in immunity to intracellular bacteria has been demonstrated in experimental model and in congenital immunodeficiency. For instance, individuals with inherited mutation in receptor of interferon gamma or interleukin 12 are highly susceptible to infection with the normal virulent mycobacteria. See Chapter 21. Numerous cytokines in addition to interferon gamma play an important role in defense against intracellular bacteria such as Mycobacterium tuberculosis. Tumor necrosis factor produced by activated macrophage and other cells recruit and activate mononuclear phagocytes to combat Mycobacterium. This is why patients with rheumatoid arthritis and other autoimmune disease who are treated with tumor necrosis factor antagonists become susceptible to the Mycobacterium infection. In some infection, the The bacteria escape from vesicle and enter cytoplasm of infected cells. For instance, Listeria produces a protein that creates holes in phagosomes membrane and enable the bacteria to escape into cytosol, thus evading the microbicidal mechanism of phagocytes, which are concentrated in the phagolysosomes. For eradication of such infection, the infected cells have to be killed by cytotoxic T cells, which recognize cytosolic peptide displayed by class 1 MHC molecules. Thus, the effector of cell-mediated immunity, namely CD4 T cell, that activate macrophage and CD8 cytotoxic T cell function cooperatively in defense against intracellular bacteria. So here is figure 16.6, cooperation of CD4 and CD8 T cells and defense against intracellular microbes. Intracellular bacteria such as Elo monocytogenes are phagocytosed by macrophage and may survive in phagosomes and escape into the cytoplasm. CD4 T cell respond to class 2 major histocompatibility complex associated with peptide antigen. So phagocytosed bacteria in vesicle and cytoplasm, and we see here these the antigen presenting cells. So they are presenting it to CD4 T cells, the CD4 with ligands. They cause more activation of this killing of bacteria by phagosomes if it is in macrophage. Bacteria in cytoplasm, if it's existing, then it continue, then it has to be taken back. It has to be killed by CD8 T cell if it escapes the phagolysosome. So normally CD4 is able to do this. If it fails, then it is presented to CD8 cytotoxic T cell. And we'll learn later on its cross presentation. Derived from intercellular vesicle, these T cells produce interferon gamma and expresses CD ligands, which activate macrophage to destroy the microbes in CD8 T cells respond to class 1 associated peptide derived from cytosolic antigen and kill the infected cell. Cytotoxic T cells, cytolytic T cell. The macrophage activation that occur in response to intracellular microbes is capable of causing tissue injury. This injury may be a result of delayed type hypersensitivity, reaction to microbial protein antigen, or because intracellular bacteria have evolved to resist killing within phagocytes, they often persist for long period and cause chronic T cells and macrophage activation, which may result in the formation of granulomas surrounding the microbes. The histologic hallmark of infection with some intracellular bacteria in granulomatous is granulomatous inflammation. This type of inflammation reaction may serve to localize and prevent spread of microbes, but it is also associated with a severe functional impairment caused by tissue necrosis and fibrosis. In fact, necrotizing granulomas and fibrosis scarring that are accompanied by granulomatous inflammation are important cause of tissue injury and clinical disease in tuberculosis. Individuals who have been previously infected with M. tuberculosis show cutaneous delays type hypersensitivity reaction to skins challenge with the bacterial antigen preparation, purified protein derivatives. This is the basis of commonly used skin test to detect the previous infection. Difference among individuals in pattern of T cell response to intracellular microbes are important determinant of the disease progressions and clinical outcome. Repros, which is caused by Mycobacterium repri, is considered an example of relationship between the type of T cell response and disease outcome in human. There are two polar forms of repros, the repromatous and tuberculoid forms. Although many patients fall into less clear intermediate group, in repromatous repros, patients have high specific antibody titer but weak cell-mediated response to M-repertory antigen. Mycobacterium proliferate within macrophage and are detectable in large number. The bacteria growth and persistence but inadequate macrophage activation result in destructive lesion in the skin and underlying tissue. In contrast, patients with tuberculoid reptiles have strong cell-mediated immunity but low antibody level. This pattern of immunity is reflected in grammatas that form around nerves and produce peripheral sensory nerve defect and secondary traumatic skin lesion, but with less tissue destruction and deposit of bacteria in the lesion. One possible reason for the difference in these two forms of disease caused by the same organism may be that there is a different pattern of T cell differentiation and cytokine production in individuals. Some studies indicate that patients with the tuberculoid form of the disease produce interferon gamma and interleukin 2 in lesion, indicative of T helper 1 cell activation, whereas patients with the Repromatus repros produces less interferon gamma and may exhibit weak cell-mediated immunity and failure to control bacteria spread. The role of T helper 1 and T helper 2 derived cytokines is determined by the outcome of infection has been most clearly demonstrated in infection by protozoan parasite Leishmania major in different strains of inbred mice discussed later in this chapter. Immuno-evasion by intracellular bacteria. Intracellular bacteria have developed various strategies to resist elimination by phagocytes. These include inhibiting phagolysosomes effusion and escaping into cytosol and directly scavenging or inactivating microcidal substance such as ROS. The outcome of infection by these organisms often depend on whether the T cell stimulated antimicrobial mechanism of macrophage or microbial resistance to killing gains the upper hands. Resistance to phagocytes mediated elimination is also a reason that such bacteria tend to cause chronic inflammation that are difficult to eradicate. Some of these infections, notably tuberculosis, may last for years. The bacteria survive in the quiescent latent state with phagocytes and often become active, especially in the immune system if the immune system is compromised. Immunity to fungi. Fungal infection, also called mycosis, are an important cause of morbidity and mortality in humans. Some fungal infections are endemic and these infections are usually caused by fungi that are present in the environment and those spores enter human. Other fungal infections are said to be opportunistic because the etiologic agents cause mild or no disease in healthy individuals but infect and cause severe disease in immunodeficient persons. Compromised immunity is the most important predisposing factor for fungal infection that cause serious illness. Neutrophil deficiency as a result of bone marrow suppression or damage is frequently associated with such infection. Opportunistic fungal infections are also associated with immunodeficiency caused by HIV and therapy for disseminated cancer and transplant rejection. Different fungi infect humans and may live outside the cell in many tissue or within phagocytes. Therefore, the immune response to these microbes are often a combination of response to extracellular and intercellular microbes. Innate immunity to fungi. The principal mediator of innate immunity against fungi are phagocyte and the complement system. Phagocytosis by neutrophil and macrophage is important for controlling fungal infection in tissue. These phagocytes defect fungal molecule by variety of pattern recognition receptor including toll-like receptor and lectin such as dectin and mannose receptor. Neutrophils seem to be especially important in defense against predominantly extracellular fungi, and disseminated fungal infections are frequently complications of conditions associated with neutropenia such as leukemia and cancer therapy that compromise bone marrow function. Neutrophils and macrophage liberate fungocidal substances such as reactive oxygen species and lysosomal enzymes and phagocytose fungi for intracellular killing. Complement activation is mainly involved in defense against fungal that enter the bloodstream, such as Candida organism. Fungal may activate alternative or lectin complement pathway. Complement products opsonize fungal for phagocytosis but may not directly release the fungal because of their thick cell wall, which resists killing by MAC. Adaptive immune to fungus. T helper 17 cell play a critical role in adaptive immunity to extracellular fungal infection in tissue. Fungal such as Candida frequently infect epithelial tissue such as the skin and oropharyngeal mucosa. Other fungal often infect gastrointestinal tract. In all of these locations, fungal induce T helper 17 response, in large part because fungal carbohydrates stimulate dendritic cells and macrophage by receptors such as dectin to liberate cytokine that promote T helper 17 differentiation. T helper 17 cell recruit neutrophil that phagocytose and destroy the fungi. Predictably, the most prominent complication of inherited mutation affecting T helper 17 development is chronic mucocutaneous candidiasis. T helper 1 mediated cellular immunity is an important defense mechanism against intracellular fungal infection. Histoplasma capsulatum, fasciculative intracellular parasite that lives in macrophage, is eliminated by the same cellular mechanism that is effective against intracellular bacteria. CD4 T helper 1 and CD8 T cells cooperate to eliminate yeast form of Cryptococcus neoformans, which tend to colonize the lungs and brain in immunodeficient hosts. Pneumocystic girovec is another intracellular fungal that causes serious infection in individuals with defective cell-mediated immunity, such as patients with AIDS. Bone marrow failure, often resulting from leukemia and inherited deficiency in CD40 ligands. See in chapter 21. The T helper 2 response are thought to be ineffective at clearing fungi and cause harm. In Aspergillus infection of the airway, T helper 2 response against the fungus causes serious inflammatory reaction called allergic bronchopulmonary aspergillosis. Little is known about fungal event hosting immunity. Virulent strain of C. neoformans inhibit the production of cytokines such as tumor necrosis factors and interleukin 12 by macrophage and stimulate production of interleukin 10, thus inhibiting macrophage activation. So let us end up there for first hour, then we continue with immunity to virus.